and hit record. And I'll pass it off to Becky to do the introduction. Thank you.
Thank you, Sonia. And welcome everybody to a lunch and learn, actually. We're so glad to have you here, and thank you for being with us here today. My name is Becky Daughtry, and I work for the Healthcare Authority as the First Episode Psychosis Project Lead. We're so thrilled to see many of you joining this morning, and equally thrilled to bring you our keynote speaker, Pat Deegan. For over 30 years, Pat has been a thought leader and disruptive innovator in the field of behavioral health and recovery. Pat received her doctorate in clinical psychology and is the founder of Pat Deegan and Associates, a company run for people in recovery. The mission of this organization is to safeguard human dignity by bringing individual voice and choice to the center of the clinical care team. Towards this end, she developed Pat Deegan's recovery approach. Pat's work has been an integral part of the development and training for New Journey's First Episode Psychosis work in Washington. I also want to introduce Missy Rufo. She is the Director of Coaching and E-Learning at Pat Deegan, PhD and Associates. Missy is a certified personal medicine coach, as well as a certified personal medicine trainer. Missy learned about personal medicine back in 2007 at a conference and instantly connected with the content and immediately began to incorporate it into her work at a psych rehab program. She really talked about learning so much from the people she was serving and began to see them grow in their confidence and start taking more steps forward. Missy talks about learning things that were personal medicine and helped her to work even harder to help others find the healer within. She loves the work she does with Pat Deegan and Associates, and it is her passion that drives her to do the work that she does here. So let us welcome both Pat and Missy to carry a message of hope and recovery to audiences around the world. And without further ado, I welcome you.
Well, hi, everybody. Thank you very much, Becky. I'd like to just take a moment and thank you for coming to today's webinar, and to also just to step back for 1 minute from our busy and hectic work worlds to say thank you for what you do. I like to remind us that the work we do is very important. I think sometimes in the work we do, we hear a lot about what doesn't go right. But you and I know that a lot does go really right, and that every single day we are reaching out and touching people's lives in incredibly important ways. And I know this because for 40 years or so, I've been collecting individual stories and making videos of people's recovery narratives. And what people talk about is the simply human touch that we bring to the work. Our professional skills, our areas of expertise are all terribly important, and I couldn't agree more with that sentiment. But beyond that, or at least grounding all of the important technical work that we do in our professions, there's the fundamental fact that we are meeting the people we're working with on the common ground of our shared humanity. And that's ultimately what people talk about when 5 years later, 10 years later, they sit down with me to tell me their recovery story. And what they mention is not so much the extraordinary DBT skills of their primary therapist, although I think sometimes I know many people who would share that DBT was a key in their recovery journey. But really what pretty much everybody starts out with was that one of us touched their lives in a simply human and hope-filled way. And that human touch is what no artificial intelligent bot is going to be able to do. And what ultimately is a factor, an important factor in people getting to the life that they want to live. And that's more or less how I define recovery. Recovery is about, getting to the life that I want to be living. And so thank you for what you do. It is important. And I celebrate you. Now, I'm going to take a moment and share my screen. Okay. So today, what we're going to be focused on is an overview of my latest work. And this work is medication empowerment.
Hey, Pat, I'm not seeing your screen.
Not seeing my screen. Thank you, Missy. So I'm going to share my screen. That's why Missy gets paid the really big bucks. Thank you, Missy. All right. Yeah. So today what we're going to be doing is do an overview of my latest work, which is medication empowerment. Now, I'm not going to do a deep dive into the content of medication empowerment. So if you're looking for a deep dive today into the content of medication empowerment, that's not my purpose. My purpose is to introduce those of you who are working in the Washington Healthcare Authority first episode programs, introduce you to this new tool called medication empowerment and give you an idea about how best to use it on coordinated specialty care teams, on assertive community treatment teams, and in other types of behavioral health work. With that caveat, I'm going to begin with a high-level overview of medication empowerment, which is captured on this one-page PDF that you have as a handout for your work today with me. So in this handout, you basically just get a thumbnail of what it's all about. But I'm just going to start with the first third of it, which is, why did I even think there was a need for this thing that I've come to call medication empowerment? And I think to summarize my thinking here was that psychiatric medications can definitely help young folks who are diagnosed with a mental illness. It can help people reach their goals for their lives. Not all people benefit from psychiatric medications, but certainly many do benefit from psychiatric medications and find them to be a helpful tool in getting to the life we want. However, and here's the rub, is that psych meds, especially when we have to use them over time, right? When we choose to use them over time, it can be challenging to use them. There are many challenges on the journey to use these medications optimally to support us in our recovery. And therefore, what we find is that rates of non-adherence can be quite high, as we're going to see some data on that in a minute. And so for me, medication empowerment was an effort to create strategies that all members of the coordinated specialty care team can use, all members can use to support people through these challenges that are associated with using meds optimally to support recovery. So in summary, it can be really challenging to use medications over time, that the adherence model and compliance model often are not effective in supporting people in using meds optimally, and that all members of the team, not just the licensed medical professionals, the nurse practitioners, the psychiatrists, physician's assistants, and nurses, typically we kind of shove all of the work around meds say, let's talk to your doctor about that. In my approach, I'm saying that medication empowerment is something that all members of the team can use. And what it means is it brings us closer together as a team to support people in getting to their goals for their life. And so I'm very excited to have this chance today to share a little bit about medication empowerment. So let's take a little bit of a deeper dive into this question of why medication empowerment. So as I mentioned, after a diagnosis of a serious mental illness, psych meds can help many people reach their life goals. It's not as simple as swallowing a pill and being restored to my former self. That is not the experience that most of us have. In fact, for many of us, recovery is a transformative journey in which we become something new and perhaps something that we never quite anticipated we wanted to become in our lives. So recovery is possible, and that a very important tool on that journey for many of us can be psychiatric medications. And I think any of us in the room today who has personally experienced psych meds as being helpful, or who has seen somebody use psychiatric meds with a good outcome, can say, yes, this is an important treatment option for the folks that we are working with. You know, I think of somebody I know who tried and tried and tried all kinds of different medications, and then began a trial of Clozaril, and she describes it as my miracle drug. She said it gave me an opportunity to think more clearly about myself and my life and my situations, and she found it to be an important turning point in her life. Not the only one, but certainly an important one. And so I think all of us have had an experience like that, where we see a person really, really benefit. However, the truth is that in our practice, non-adherence is high. And systematic reviews of medication adherence, this recent one in 2020, shows that for folks diagnosed with a serious mental illness, 44 to 56% don't use medications as prescribed on a consistent basis. And so what we call non-adherence, non-compliance, is striking. Almost 1 out of 2 people will not use meds as prescribed over time. So you'd think that with an intervention, a treatment that has good potential for really being helpful, that we would have very robust ways of supporting people in using them optimally, right? I mean, that to me seems like a no-brainer, right? And yet it's fascinating. When we look at typical interventions to promote med adherence, and this comes from a paper that Missy and I and Allison published in Psych Rehab Journal in 2024, here's an overview of what's out there. Probably the most ubiquitous thing we hear out there when it comes to having conversations with people about meds is we say a lot, you should really talk to your doctor about that. It's really important for you to talk to your doctor about that. Have you talked to your doctor about that? You know what I'm saying? And that's the most ubiquitous. I think that's we're all good at this one, right? So it's kind of like saying, okay, you're challenged by this. Take that into the provider. Another category of interventions would be called involuntary measures. And these, of course, include involuntary hospitalizations to take meds, outpatient commitment to use meds consistently in the community. And then there's this emerging literature, which I find pretty fascinating, on this topic that gets called informal coercion, or to phrase it a little less harshly, I think, treatment pressures. And what this gets at is the idea that sometimes we use our positive relationship with a person who is prescribed psychiatric meds to kind of communicate the idea that we want to influence you in a positive way, to make the decision to use meds and to improve your adherence. And Paul Applebaum is a well-known legal scholar in psychiatric care. And he developed the first conceptual analysis of this thing called treatment pressure. And it's been fairly widely studied at this point. And he says one of the things we commonly use is a kind of persuasion. A persuasion involves kind of influencing people to make the right decision about using meds by, a rational argument, right? So these meds will help you do this, and really trying to appeal to the rational decision-making part of a person. That's what persuasion is about. But then there's also kind of interpersonal leverage. So like, I'm going to be a little crisper with you if you're not going to be adherent with meds, a little less, I don't know, empathetic and available, this sort of more subtle kind of emotional persuasion. And then it even escalates a little more than that. And especially around people who've gone off meds more than once and have had a rough time, there can be what Paul Applebaum calls, inducements. And these inducements are like a proposal, like if you stay on your med, you'll be able to stay in your housing, or we'll help you get housing. And you'll be eligible for that Section 11 or whatever it might be. And so we're saying your life, if you're going to use meds, your life is going to get better. And there's a little pressure there to influence a person's decision. And another common way that we use this treatment pressure is to also suggest to people that, look, if you don't take the meds as prescribed, you might end up back in a hospital. I might have to, involuntarily commit you to the hospital. You remember what happened last time? There's just this kind of definitely treatment pressure to get people to use the meds as prescribed. So these are involuntary and informal treatment pressures. Another category is education. This is where a tremendous amount of our effort goes, I think. We have medication education groups, individual med ed. During the nurse check-in, you come in for your injection and the nurse answers questions about side effects or concerns. And then we have lots of information and a lot of sort of during the brief medication visit, a lot of problem solving kind of in the moment in vivo. Another emphasis is programmatic. So we encourage people to get on long-acting injections. We meet with the family sometimes and get the family to support medication use. We also have some programs where we have med drops and mobile med teams. And there's also many clinics around that I've run into that pair your willingness to get the injection with the distribution of your entitlement. So here's your shot, great. And here's your SSI check for the month, great. And that kind of pairing is one of these, there's some pressure there, right? I'd be pressed to define that as totally voluntary. And then in addition, there are technical solutions, bubble packs, smart pills, medication event monitoring caps, that every time I take the cap off my pill bottle, it goes to a dashboard that my provider can see, and I can gauge adherence to that. And then, of course, these days we've got more reminder apps, phone calls, and that kind of thing. So even though we have this array of interventions, all the way from involuntary to technical to programmatic and education, the bottom line is that rates of non-adherence with prescribed psychiatric medication remain. Half to 2/3 of folks in time don't take it as prescribed. So it's not really all working that well, right? I think we can do better, perhaps. And I think one of the core reasons that these interventions fail is that medication education really is limits. It has very real limitations. Medication education is aimed at the rational dimension of decision making, right? So we offer med education in order to increase an individual's knowledge about the conflict that they may be experiencing. So I may be experiencing a lot of weight gain on while using an antipsychotic medication. And so if I was in a medication education group or working one-on-one with my provider, they might talk to me about what I could do to eat differently, what I might do to exercise differently, what I might do to mitigate this unwanted effect of medication. But this conversation is happening at the rational level. The truth is, and we know this through a lot of research, that decision-making for us humans is not simply a rational process. Decision-making has a very, very powerful affective dimension. All the med-education that we're doing is not touching so much this other dimension, this important dimension of decision-making. Examples. Trevor. First they told me I have psychosis and need to use meds. Now they're telling me I need to take metformin because I'm getting diabetes from these meds. My grandfather died of diabetes. He got his leg amputated. No thanks. I want off these meds. That's getting at the powerful affective dimension, right? Another example, this is Kenji. I don't really care about meds. I don't care if I go back to the hospital. Plenty interesting people there too. Med-ed is not going to get at this. Okay, if you can see that, med-ed isn't gonna help here. Theo, he likes weeds. He likes his weed, and he thinks it works better for him than the meds. I like my weed. I like my drugs better than your drugs, right? And I think we see this with increasing prevalence among young people diagnosed with early psychosis. Kiara, I don't trust the white doctor who gave me those meds. She kept interrupting and talking over me, and I just felt profiled. So the whole issue of our implicit racial biases coming into our work, and we know for a fact that this does occur. And if a person walks away feeling, profiled, feeling like they weren't seen as an individual because of the color of their skin, because of their gender identity, whatever it might be, then a person is not able to establish that trusting relationship, is not sure they're getting the treatment that's right for them as an individual. And we see adherence rates, but also people just walking away from care at fairly robust levels when it comes to feeling profiled in behavioral health services. So that's another, no amount of rational talk about medication education is going to get at this. This one is huge. This is Peter, and he's saying, well, according to my mom, she likes me on this med because it makes me be myself again, she says. But I don't think so. The meds aren't doing anything for me. They don't work. And this gets at the really profound question of who gets to say if meds are working? We ask people that all the time. Are meds working? What do we even mean by it? We rarely get to that level, okay? And if mom says meds are working and Peter's saying, no, they don't work, who's right? Right? This came out of a real scenario, and Peter said, if you think these meds are so fabulous, you take them yourself, Mom. It'll calm you right down, right? And he's like, they're not working for me. They work for you. So this is another example of this affective dimension of decision-making that no amount of med education is going to get at. And folks, what are we doing about this? What? And I guess this is where my sense of urgency for working with medication empowerment comes from, because med empowerment is going to take us into this zone where it gets murky. Another very important thing I want to mention is this idea that meds can change us. So when we think about, I'm thinking about myself as a young person who was experiencing my first episode of psychosis, and brought to a psychiatric hospital. Prior to going crazy, prior to experiencing psychosis, I knew myself as Pat Deegan, a good athlete, terribly mediocre student, but a really good athlete who was going to become a gym teacher, right? That was the big idea. That was regular me. And then this other thing happens in my senior year. I experienced what I'd come to understand was psychosis. Oh, this is different. This is scary. This is terrifying. I feel like my world is coming to an end. I'm scared of everything. Me with psychosis. I get to the hospital and everybody starts telling me, look, Pat, don't worry. If you take the medication, it's going to return you to baseline. That's when we talk about that all the time in behavioral health, right? If you take this med, it's going to take you out of psychosis and return you to baseline, right? And that's what we're going to hope for and strive for and everything else. The problem is that medications did not return me to my regular me. I would dare anybody in this room today to take 40 milligrams of haloperidol, which is still a frontline antipsychotic medication used very widely, right? And that was what I was put on, and to go play basketball at state finals. No, not on that much Haldol, no way, right? So what I found and what I experienced, and I think many, many young people do, is these meds don't return me to regular me. These meds set up a third state. And this third state is what I call me on medicine. Me on medicine, right? Me on medicine is kind of a lonely place because guess what? Most of our behavioral health services don't know how to talk to people about me on medicine and accompany them on the journey into who am I now that I take psychiatric medications? What does it mean that I take? Does this mean that I'm crazy? Does this mean that I'm weak? That I'm using meds as a crutch? Maybe I should just pray more. Are these side effects really worth it? Seems like the cure is worse than the disease. All of this stuff. And we're kind of on our own with the never-ending message to your doctor about that. Well, dang, the doctors rarely have time to spend the time needed to have this conversation, right? This is really real. This is what the young folks we're working with are challenged with. And this is why I feel so passionately about medication empowerment. And it's because the adherence and non-adherence framework often fail us. It's a binary construct, just like a light switch. You either are adherent or you are non-adherent. And of course, I'm making the point that there is a very big divide between the emotional components, psychological experience of using meds. So adherence does not equal, what adherence means is that you're taking the correct dose at the correct time. But I can be taking the correct dose at the exact same time and still not be using medications optimally to support me getting to the life I want. So when I talk about optimal use, it means I've figured out how to work with a psychiatric care provider. That's no small feat for many of us, right? I've learned, I've been able to work with my provider to get to the fewest number of meds at the lowest effective dose. And that the trade-offs of using the meds, the unwanted effects, the risks to my health, the long-term benefits of using, these things are balanced out. And my gosh, it takes most of us a long time to find this right balance, right? Optimal use is much more than just being adherent. Okay, it means I've figured out my personal motivation for using this drug. It means I'm experiencing medications as working in ways that matter to me, not to my mother, that matter to me because I'm the one taking them. It means that my story of self, who I understand myself as, is Pat Deegan. That story of who I am aligns with being a person who uses meds. And for people like me who are, it's recommended that we use psych meds at a fairly young age, that's a really tough alignment to make to the story of myself as the athlete with a future career in professional coaching and all the things I dreamed of. And then me on heavy-duty antipsychotic meds. Those two stories don't go together. And so there's an amazing effort to try to align who I understand myself to be with this new me, this medicated me. Okay. Importantly, meds don't recover us. So in addition to learning to use meds optimally, we also have to learn to use what I call our personal medicines, the things we do, the self-care strategies we do to be well. Using meds eventually, in my experience anyway, if we are approaching optimal use, what that looks like is on a given day, using meds kind of fades to the background, and center in my life is really what matters to me. It's my focus on most days, right? So being able to say, on most days, I'm able to do this work that I love, and using meds is just this thing that kind of is way in the background there. And every now and again, it comes forward and needs to be examined. And I don't know anybody who's 100% comfortable with using meds. And whatever we do, we should never say to somebody, look, you've got an illness from which a chronic disorder from which no one can get well. And oh, by the way, you'll have to take them for the rest of your life. That's like, I call that the prescription for noncompliance. That's just like, what are we thinking saying that to people? A, it's not true. Okay, nobody can predict, has that crystal ball to predict it. But anyway, this idea of taking meds because it's getting me to the life I want today. And I think that's really where we are in terms of defining optimal use of meds. I can focus on what matters to me today. Okay. Simple example. This comes right out of some real work that I've been doing with people and with teams working with young people with early psychosis. So this is Coral. And she is a Caribbean American female in her early 20s. And she is diagnosed with schizophrenia, and she's been enrolled in a coordinated specialty care team for 15 months. At the start, this is 15 months ago, at the start of her participation, she was prescribed a long-acting antipsychotic. And she was consistent with taking meds, but she always reported very ambivalent feelings about it. And her mother did as well. And the concerns had to do with side effects and whether or not meds were in fact the right treatment approach. So there was some effort put by the team to do psychoeducation on the benefits and risks. And this was provided to both Coral and to her mom, which I think is good practice for a team. And throughout, a shared decision-making approach was used throughout this course, 15 months course of treatment. However, Coral discontinues taking the meds 3 months ago with support of her mother. And she continues to meet consistently with the provider for check-in and monitoring of symptoms on a monthly basis. But here's the rub. Ever since she began care, she's reported these ambivalent feelings about it. Psychoed was applied, okay? And because she was taking it, that's as far as it went. Right? She was taking the injection. In my opinion, medication empowerment is an approach that will help us be upstream and get to working with people around these challenges early on in care, okay? So that we can avoid disastrous or abrupt or unplanned discontinuation further downstream. So my approach, I call it medication empowerment. And let's see how we're doing. So I have to hubba through this a little bit because Missy's got to give you some important information. So I'm going to skip this next slide and go to the next part of the handout, which is, so what exactly is it? You said why it is, Pat, but what exactly is it? And so medication empowerment, as you can see on your handout, is actually 14 animated videos that we can work and use directly with program participants. It includes challenges as well as foundations of how to work with a psychiatric care provider. And it includes an interactive self-report where at some routine time, whether that's treatment planning, intake, annual individual service plan, whatever we want to, whatever makes sense for our program, we can invite people to do a self-discovery exercise to discover and put words to what, if any, challenge am I experiencing with using the meds that I'm prescribed at this time in my life. So we're actually getting proactive and inviting people. In addition to all of these really concrete tools, medication empowerment also includes learning tracks, one for peer specialists who want to know about the medication empowerment approach, and one for providers who also want to gain mastery in this approach. So 4 foundational videos. And for me, these are the basics of what everyone who uses psych meds should know. You've been diagnosed with a mental illness. Okay, but guess what? You're not an illness. You're the one who's going to recover. And that here's some basics about how to work with a doctor. I mean, nobody teaches us that. And yet it's an incredibly important skill. We have to kind of stumble into it. Why not teach people right up front? Here's how to work with a doctor. That when we meet with a doctor, there are 2 experts in the room. One is, of course, the licensed medical professional, but the other expert in the room is me. I'm the only one who can say how this medicine is affecting me. Okay. The 3rd foundation, my goal for treatment. The 4th foundation is, okay, you've been prescribed psychiatric meds, now what? Total runtime, these run 3 minutes each for a total of like 12 minutes. They also come with interactive exercises that you can do right after watching the videos. These forms are in English, they're in Spanish, and they are form fillable, so you can use them in telehealth. Let me give you a sample.
My goal for treatment. Many of us find that having a clear goal for medication treatment is helpful. Here's what I mean. Imagine me and my doctor are in a rowboat that has 2 sets of oars. My doctor is rowing one way. I am rowing in a different direction. Let's say I am rowing toward my goal of completing college. My doctor is rowing toward the goal of reducing my symptoms with meds. But the meds are making me so sleepy, I can't wake up on time for school. Clearly, when my doctor and I are rowing in different directions toward different goals, we won't get very far. The solution is obvious. We need to start rowing in the same direction. And for that to happen, we have to agree on where we are heading. Because it's our life and our treatment, it's best to share our goals with the doctor. A 2-step power statement can help us tell the doctor about our goal for medication treatment. I want to work together to find a medicine that will help me sleep better so that I can wake up on time for work. Here's another example of a power statement. I want to work together to find a medicine that will help me manage my temper so that I can get along better with my family. Of course, you can fill in your own power statement with your goals. It's best to write down a power statement and give it to the doctor. If goals change or if we have new goals, it's important to update our power statement. Even if we've been working with the doctor for a long time, it's still a good idea to create a power statement so the doctor can get on board with where we want to go.
Okay, power statements are one of my most favorite things in the whole world. I think that they're profoundly simple. We've published and in major journals on the scalability of power statements. Peer specialists do an amazing job helping people do high fidelity power statements. And all I can say is they're the bee's knees because it helps me say how I want treatment to help me. What could be more fundamental, right, than this? And so I'm a visual person. Let me give you an example. So this is Jamie. He creates a power statement after watching the video and using the worksheet. And he creates his power statement and it says, I want you to help me find a medicine that will help my voices quiet down so that I can pay attention to my boy when I have him on weekends, right? And that's clear. And what's powerful about that is if treatment is not getting Jamie being able to focus more specifically on his son on weekends when he has custody, then treatment's not working. I don't care how much his GAF score and all the rest of it has gone down. If he's not able to achieve this goal for treatment, then we haven't gotten there yet, folks. And that's the power of power statements. It's an N of one study. It connects the treatment team's plan with what matters to Jamie and creates a shared understanding of what the heck the goal of treatment with Jamie, not for anybody, but for Jamie. What is this goal for treatment? Okay. The next part I talked about was after the foundations comes the opportunity for self-discovery and exploring our challenges. And as I mentioned, there are these challenges that many of us experience. We don't all experience all of them, but many of us experience a number of them, right? And so part of medication empowerment is an opportunity for people to do a self-discovery exercise using a video where they can explore what challenges they might be experiencing. And these challenges include things like, we met Theo, I like to get high. Another challenge, meds aren't working for me. That was Peter. I have side effects. Meds have changed me in ways that I really don't like, right? I'm not motivated to take medicine. I'm questioning meds. I'm thinking maybe a sweat lodge is going to work better for me than a lithium, right? I'm concerned about how meds are affecting my health. I'm thinking about having a baby. I don't want to become toxic on medicine, right? Or perhaps I'm like Trevor, developing a metabolic syndrome on an antipsychotic. The old-fashioned thing, I'm just tired of taking pills. I'm on so much medicine, I can't even tell you what they are anymore and what they're for. And I'm afraid to speak up because if I speak up, guess what will happen? They'll give me more medicine. They'll give me a pill for the pill. And then sometimes it's hard to trust a white doctor, and that gets into the whole area of biases. These are the challenges. Plus, there's a place on the worksheet for an individual to put it in their own words. So I feel like a guinea pig on all these meds, is something someone might say. So let's just take a look at Kenji. He is invited by his team. It's treatment planning time, service planning. And he does the Exploring My Challenges worksheet with his peer specialist from the team. And he says, I identify, I'm not motivated to take meds. And what he's responding to in the video is where it says, I haven't found my own unique personal motivation to use medicine. My family or friends want me to take meds, but I don't want them. So he hasn't discovered any kind of personal motivation. We're able to catch that, and we take it seriously. In talking with Kenji, he says, I don't really care about meds. I don't care if I go back to the hospital. There's interesting people there too. What do? This is that affective dimension of decision-making about meds. Well, the first thing we do is we go to medication empowerment and we take out the challenge video about what? Motivation. Here's a brief look at this video.
I'm not motivated to take meds. Imagine you're in a running race. Friends and family are there at the start line cheering for you. Your heart is pounding, and when the whistle blows, you feel a big burst of energy as you sprint down the track. But the further you run, the more you feel like you're running out of gas. Well, it can be really hard to keep on running when we don't have enough energy. So in some ways, motivation is like having enough energy to go the distance. For example, we might feel really energized to take meds in order to get out of the hospital. But once we get out, we may start running out of gas. Our family or friends might tell us to keep using the meds, and our doctor might say it's best for us to use the meds. A judge might even court order us to take meds. My fourth tip for finding personal motivation for using meds is to identify the things our mental health challenges are interfering with. Start by making a list of 3 things that mental health challenges are interfering with. For instance, I might say, my mental health challenges are interfering with watching football with my friends, going to church, keeping a job. Each one of these can become a personal motivator. All I have to do is to put them in this sentence. I am using this medicine so I can watch football with my friends. I'm using this medicine so I can go to church. I am using this medicine so I can keep a job.
That gives you just a short clip of that particular video. And so to use this strategy that we just learned in the video, first we used the Exploring My Challenges worksheet with Kenji. Then we watched the corresponding video to the motivation challenge. And now we have a support strategy that we can begin to use over time with Kenji. So we're going to start by listening and really trying to understand his experience. And we're going to ask a key question. Is there anything that blank, and in that we want to have a symptom of some sort, if you will, trouble sleeping, trouble focusing, anything that blank is keeping you from doing that you wish you could do again? So Kenji, is there anything that trouble concentrating? And that's his words. That's how he understands what's bugging him. I'm having trouble concentrating. Is there anything that's keeping you from doing that you wish you could do again? And he said, well, I get kicked off my League of Legends team because I'm too spaced out and it'd be fun to play again. Okay, so what we have is the beginning, the kernel of motivation, right? So we can flip that around to create a personal motivator. I am using this medicine so that I can play League of Legends with my boys again. Okay, and so we're beginning to build that sense of what matters to Kenji and why this medicine may be helpful to Kenji. And in addition, over time, we can then help to reinforce that and help Kenji reinforce that motivation with himself. This is a technique I used personally, which was to put an image or words on the actual pill bottle, so that when I would take the pill bottle, I would say, this one is for staying out of the hospital. This one is for being able to sit through my classroom, through my classes and graduate. So he puts, of course, League of Legends on his, and it's a way to reinforce. So I do believe, friends, that we can do a whole lot more than say, talk to your provider about this. And there are, as I mentioned, all kinds of challenge videos. Meds have changed me in ways I don't like. Sometimes it's hard to talk to a white doctor. I'm over-medicated. I'm questioning meds. All these videos are part of medication empowerment. And then finally, how to adopt it. And that's what the graphic is at the bottom of your handout. There are the foundations. We ask ourselves, how can we expose to people about the foundations of what I need to know in order to work with my psychiatric care provider? Then there's that self-assessment piece, where people get to go through that worksheet and watch the video and say, hey, this is what I'm going through. I'm not motivated. Then we can watch videos related to the challenge that the person has selected. And then if we have studied the course material as a practitioner or as a peer specialist, we can be knowledgeable about how to support somebody. So this is what's inside of medication empowerment, inside the learning management system that you'll be having access to. And just finally, I want to point out that it's also optimized for mobile devices. So you can use it out there on your iPad or on your phone and really get sort of high fidelity use of this incredible resource. So on that note, in the little time, I turn it over to Missy.
Thank you, Pat. And if folks have questions, please feel free to, put them into the chat or into the Q&A. We're happy to answer any questions. So I just want to mention, so for those of you who are on the call who are part of the Washington Healthcare Authority New Journeys teams or ACT teams, you do now have access to all of the medication empowerment tools that Pat just talked about. I'm going to show you how to access those in a second. So if you already have an account, if you already have access to Academy Plus Library, when you log in now, you will also see 3 new blocks that say medication empowerment. And if you haven't done that yet, that same link to register for Academy Plus Library will give you access to medication empowerment. So let me find my screen button. So I just want to go over and just kind of give a quick, where'd it go? Overview of how this works. So you can see my screen okay?
Yes.
Okay. So as I said, if you already have access to Academy Plus Library through the Washington Healthcare Authority, then you just need to go to patdeegan.com and /login and log in to access that. If you don't, you can create an account here. Just going to do that really quickly to show you what happens when you register. And once you register, you're going to get an email that's going to give you all of this information. So you can review this, take a look at it from here, but you're also going to get an email. So all of these materials, Academy Plus Library, Medication Empowerment, you will access at patdeegan.com/login. And if you've just created your account, you're already logged in. So you're just going to go to your collection. And as you can see here, you should see 5 blocks. So you have Academy, you have Library, Medication Empowerment Materials, which is where you're going to find all of those videos and all of those worksheets that Pat talked about. And then you're going to see both learning tracks. So you can select the one based on your role. If you're a peer specialist, you're going to go to the peer learning track. If you're a practitioner, so if you're a CES, if you're a therapist, if you're a psychiatrist or a nurse practitioner, or a nurse or a psych rehab specialist, whatever, any other ones, you're going to go to the practitioner learning track. And as Pat mentioned, they're very similar. They follow the same pattern. The peer specialist one just addresses a few extra things, right? So peers, we know, have an important role to play in supporting people in using meds. And so there's a collection of videos here on the role of peer supporters. So Pat talks about the roots of peer support and psychiatric medications, the peer supporter and psych meds, how to address involuntary commitment medication, and the peer supporter. And so these are really great. Sometimes as peers, you don't always receive the training around how to talk to your peers about medication, and it can be kind of scary, I don't know what to say, or I don't know what the right thing is to say. And so this will really be a helpful resource to be able to do that. It is designed to go into a linear fashion, so I would always recommend clicking on start. But you can, after you've gone through all of the videos, Pat talked about those foundational videos. You can go directly into that and watch just those videos if you want. And then once you're into the challenges, again, you've got all of the specific challenges that Pat talked about, right? Self-medicating, are medications helpful? I have side effects, meds in my health, motivation, exploration. Pat provides brief videos on that challenge and the kinds of questions that you can ask people who are experiencing that challenge, the things that we can look out for as peers, as practitioners, to be able to help to identify that challenge. Or if someone has completed that My Challenges worksheet and they've identified that motivation is a problem for them, I always recommend coming back and reviewing Pat's video to help you walk through, what does that look like? What does it sound like? What types of questions can I ask? And it really helps you to really kind of dive in, learn more about that challenge, get a better understanding of what a person might be experiencing in that challenge. So whether we're a peer specialist or we're a practitioner, we may not have a full understanding of what that experience might feel like. So we can go ahead and learn a little bit from Pat to understand that challenge a little bit more deeply, and then we can review those animated videos and worksheets. To find those animated videos and worksheets, as I said, in your collection, you should have seen it there, but you can also access them here under your medication empowerment materials. And so this is what you would use if you were sitting down with somebody and you wanted to review those foundations, if you wanted to do that self-report with them. There's a little video that you can watch together. There's a worksheet in English and Spanish that you can download. and have that printed out so the person can go through that and identify which challenges they're experiencing. Once they've done that, then you can help them in moving through those challenges, right? So here's all of the animated videos that Pat was talking about. And then if you click on the resources button, we've got the downloads of the worksheets in English and in Spanish. And we've also included a download of that video. So we know sometimes we're out in the field, folks don't always have access to Wi-Fi or to a data plan, but maybe they want to download it to their iPad or download it to a laptop to be able to go and view it with a person in the community. As Pat said, all of these resources are also optimized for mobile devices. And so there is a quick tutorial here on how to access and use all of the things in the learning management system. But we do have a little video here on how you can access it on your mobile device, how you can create like a thumbnail or like a saved bookmark to be able to access it quickly so that when you're in the community, if you're working with somebody, you're on the go, you're talking about some of the different challenges, you can watch a video with them. And so this video here is just a really brief overview of how you can get that on your mobile device. So it's really great to be able to do that with folks in the community. Gotta go back to my collection. And so the practitioner track, you'll see, looks very similar. There's a few less lessons because we don't have those peer lessons in the beginning. But everything else looks the same. You've got access to your medication empowerment materials. We've also included a manual that can help you in lots of different ways, right? It can kind of give you an overview of, it's loading very slowly, I apologize. It gives you an overview kind of all the things that Pat just talked about. What is medication empowerment? Why do we use this? How do we use it? And it talks about the different resources, the different materials. It gives you some sample formats that you can use for groups, which is always great. I'm a big group person. I love to use these types of tools in a group setting. Talks about how you can use it in telehealth, in the community, and then it goes through all of the materials that you have available. So use that to your advantage as you're trying to figure out what's the best way to use this with the folks that you're supporting. There's some great ideas in that manual. And then also this final pulling it together video also talks about that. So the manual goes along really well with that. And so, like I said, you can click on start here, start from the beginning. And if you've already completed something, you can mark things off. All of these videos will auto-complete when they're done.
Can be found in this course. So let's do this.
And so, as you can see, so it's already checked it off for me. So now when I go home, I've got a little bit of progress. I've completed some lessons, so you can kind of see where you've left off. Any questions about any of that? Seeing things come into chat, but I didn't get to look at them. So I love all of the videos. I love all of the animated videos. Keep things really simple for folks, and not only do they help the people that you're supporting really connect, with, hey, my experience is real. Like it's not just something like this is a real experience. This is something that other people have experienced as well, and it can be very affirming for people to be able to hear, hey, this is a normal experience too. Having challenges with these medications. And guess what? There are things that I can do about it. And so it's really great, for individuals that you're supporting, but it's also a great tool for us as staff to really gain some understanding of what people are experiencing. So whether we're a peer specialist or a practitioner, whether we've experienced mental health challenges on our own or not, we can learn so much more from these videos from the perspective of what it feels like for that person, right? So I'm concerned about meds in my health. I mean, I'm sure whether you've used psychiatric meds or not, people all have concerns about how any kind of medication might affect their health. And so the videos and the worksheets really help us to prepare to talk to a provider about that, right? So this is, here are my concerns. What am I concerned about? What have I heard about this medicine and where have I heard it? What questions might I have for my doctor, right? So people get empowered. Again, as Pat said, we go beyond medication education and we help people to find their voice, and we help people by providing these tools and resources so that they are feeling comfortable in speaking up and sharing what their experiences are. We don't always have a lot of time with a doctor to be able to dive really deep into things. So practitioners, peer specialists can really help people prepare for their appointments by watching those videos, by completing these worksheets and going in. They can also like do some role playing with them to be able to speak up and share what's going on with them. And so when folks are more empowered to share their experiences, people listen, right? I always find that people have a hard time when you go into an appointment and just say, oh, these meds aren't working, or, oh, I don't like these meds, without anything to kind of say what's going on, right? So all of these tools really help people to get really specific and concrete about what their experience is so that their provider can really see that full picture and understand what's going on, and then start working together with that person to find the solution. There's always solutions out there. There's always alternatives that are available. And so when we can help people become better self-advocates, be able to share what their experiences are, and as we as a staff can learn how to best support people, how to recognize those challenges, we can better support people in getting and keeping the life that they want.
Yeah, so thank you, Missy. There's lots of questions in the chat, and just to talk about some of them that are in here. So right now, as Sonia's saying, the subscription for early psychosis teams and PACT are for PACT and early psychosis teams in Washington State. If you come from Utah or you come from Michigan or wherever, and you're interested in your teams being able to use medication empowerment, it is a licensed product, and we have various levels of licensing. Some states buy a broad license, or an insurance company might buy a broad license, and that's an enterprise license. But there's also individual subscriptions. So if you want to, as an individual, plug in and use these in your work as an individual, there's an individual subscription to be able to access the content. And then there's smaller program. They've got, the website patdeegan.com. Just look under medication empowerment. We've got lots of options for you. And, and I'm thrilled to hear you be excited about it. Another option, if it's just not going to work to be able to purchase a license to access the information and the resources, the content of medication empowerment, I not infrequently give webinars. So an example would be in February, I'm giving a 3.5 or 4 hour webinar at Stanford on medication empowerment. And during that presentation, I will go into really a lot of depth on the various challenges, what helps, what doesn't help, and also distribute material, but won't be distributing the videos and stuff, but at least in terms of some of the worksheets. So if you feel there's just no way you can afford anything, even, I don't know what it is, Missy, $5 a month or something for an individual subscription, you can keep an eye out for my public webinars, where I go into a lot more depth than I did today on medication empowerment approaches. So on the one hand, we're trying to make a living here, but on the other hand, we're also, I think coming from a place of abundance and willing to share as well. So.
And I put the link to our website that has all the information and how to contact us as well. And if you have questions, contact us. We're happy to hop on a call and figure out what might be best if you're outside of the Washington Healthcare Authority, FEP and PAC teams. So you can access all of that over there.
Yeah. I'm looking at whether the actual date. The Stanford Clinician Series 2026. I'll put it in the chat. And I'm the February speaker. I don't have any idea what if it costs money or not to be in that in that webinar. But I do know that's one that's coming up that's going to be very in depth. Yeah. So, and you can always be in touch, pat@patdeegan.com. If you have further questions, we really are here. We're real people. We're not bots. And feel free to reach out. We can be helpful. Other thoughts? I'm really encouraged and thrilled, actually, that you're getting excited about this, because I think it's the bee's knees. I really do. I think it's just such a glaring gap in what we do for folks, and I think we can do better. And I think medication empowerment helps us get there. So thank you very much for your time. Oh, someone says, please consider creating materials for parents. Absolutely. I think the material as it is could be quite helpful for parents. But also absolutely we can do, you know, when we hit the big jackpot, we can do a bunch more. I feel like we just scratched the surface here in terms of what we did. We pulled all of this together under a contract during the pandemic. It was a great project for the pandemic to do. I want to give a shout out to the artist. She's from Washington State. Her name is Lizzie Sheehan, and she lives in Grapeview, Washington. And I think she did a great job too, bringing it all to life. Okay, we good? All right.
Pat, I think Alexa has a question.
Do you work for Amazon?
Hi, no, I don't work for Amazon. Actually, I'm a real person and I'm not a bot, like you said.
Okay.
My question was pretty much already answered about being. I live in Salt Lake City and I work in an FEP program. But I just wanted to take this moment to thank you so much. I've been following your research for a while, especially since I started in this work, and I just think this is such an amazing work that you've published. I personally feel really seen as like a peer support, because a lot of the concerns that you brought up about medication and the ways that it's typically handled with adherence, things that really bothered me as like a patient in the mental health system, and also now as a provider, that I've always been very skeptical about. And so I'm just really happy to attend this webinar and be able to bring this information back to my team and kind of like really promote this as an intervention that we could be participating in, because I feel like our clients, our participants really need this. There were cases that you brought up that really reminded me of some of our own participants. So I'm just, thank you so much.
Oh, you're so welcome, Alexa. Thanks for sharing. Yes. Okay. I think that's it, right? All right.
Thank
Bye,
you.
everybody. See you down the road.
Thank you so
much.